Welcome to this explainer. We're always thinking about the big dramatic emergencies, but what if I told you that one of the most dangerous ones can start with something as common as a simple toothache? Today, we're going to break down everything a medical trainee needs to know about odontogenic infections, how to spot them, how they get so bad, and what to do when they do.
So let's kick things off with a number that really sets the stage, 21%. According to the National Health and Nutrition Examination Survey, that's the percentage of adults in the U.S. walking around with untreated dental cavities. Think about that. More than 1 in 5 adults has a potential starting point for a really serious infection just waiting to happen.
And that brings us to the big question, right? As a clinician, you are going to be on the front lines. You have to know, when is this just a toothache, and when is this a full-blown medical crisis that needs you to act fast? We're going to trace that exact path, from a basic cavity to an emergency that could very well end up in your department.
Okay, so how does this whole cascade even begin? In this first section, we're going to look at the two main culprits behind odontogenic infections and the really serious complications they can lead to. It's all about understanding where these things start and just how far they can spread.
It pretty much always starts with one of these two. On the left, you've got dental caries, or what we all know as cavities. Think of this like a drill, boring a hole straight through the tooth's defenses, giving bacteria a direct path into the core. Then on the right, you've got periodontal disease, gum disease. This is more like digging a moat around the tooth, creating these deep, infected pockets where bacteria can just thrive. Either way, you've got a perfect launch pad for a serious infection.
And here's why this is so critical. The real danger isn't just about losing a tooth. This infection can escape. It can tunnel into the deep spaces of the neck and threaten the airway. That's a true emergency. It can literally eat away at the jawbone, or it can shower bacteria into the bloodstream, seeding heart valves and even prosthetic joints. It's even linked to a higher risk of cardiovascular problems. This is serious stuff.
All right, let's get into the how. We're going to trace the anatomical superhighways these infections use to get from point A to point B. And trust me, understanding this anatomy is absolutely key to spotting the danger signs early.
So you've got to think of these fascial spaces in the head and neck like a network of interconnected highways. There are no stop signs, no speed limits. Once bacteria break out of the tooth or the gum, these tissue planes offer the path of least resistance. It allows that infection to travel incredibly fast from, say, a back molar right down towards critical structures like your airway. So let me give you a classic and really dangerous example of this. An infection in what's called the masticator space. This usually comes from a lower wisdom tooth. Now, what's so sneaky about this one is that the swelling can be hidden deep under those big chewing muscles, so it might not look that bad from the outside. But there is one major clinical red flag that screams trouble.
And that red flag is trismus. If your patient physically cannot open their jaw, you have to assume that infection has spread into the muscles of mastication. This one single sign immediately elevates the situation. This is no longer a simple dental abscess. It is now a deep space infection that needs your urgent attention. See this, you act fast. It's a medical emergency, period.
Now, what's another really bad path this can take? Well, instead of spreading through those soft tissue planes, the infection can just invade the bone directly. That's called osteomyelitis. And you'll see this way more often in the mandible, the lower jaw, mostly because it just doesn't have as rich a blood supply as the maxilla.
So you're looking for severe, really localized pain in the jaw. But here's the absolute giveaway sign: new onset numbness or tingling in their lip or their chin on that same side. The nerve that supplies sensation there runs right through the jawbone. So when an infection starts to swell and press on that nerve, it's like static on a phone line. That numbness is a huge clue that the infection is in the bone.
Okay, you've seen the red flags. You're suspecting a serious infection. What do you do now? In this section, we're going to walk through how you confirm your diagnosis and, just as importantly, figure out exactly how far this thing has spread. The workup is all about nailing down the problem.
So to get a definitive diagnosis, you need two things: a good culture and the right imaging. And for a deep abscess, you can't just swab inside the mouth. It's full of other bacteria. You have to get a clean sample, usually with a needle aspiration from outside the mouth. And that sample has to get to the lab immediately in an anaerobic transport medium, because the bugs we're looking for hate oxygen. And when it comes to imaging, here's your decision tree. A panoramic X-ray? It's like a basic city map. It's okay for a quick look. But a CT scan is the undisputed gold standard here. A CT is like having a GPS with real-time traffic data.
It shows you exactly which fascial spaces are involved, how close it is to the airway, and if the bone is affected. It is absolutely essential for planning any kind of surgical intervention.
So, we've found the infection, we've mapped it out with a CT. Now, how do we stop it in its tracks? This section is all about the two pillars of treatment, getting the source out and hitting it with the right antibiotics. And getting this right is, well, everything.
I want you to burn this into your brain. Antibiotics alone will not cure a deep space infection. You can pump in all the IV meds you want, but if you don't drain the pus and remove the source, whether that's a dead tooth or infected tissue, the patient will not get better. For these pus-forming, pyogenic infections, surgical drainage is the definitive treatment.
Now, of course, antibiotics are a crucial part of the plan. For your typical healthy patient, something like ampicillin-sulbactam is your workhorse. Think of it like a shotgun. It has great coverage for the usual oral suspects. But if you're dealing with a severely immunocompromised patient, you need to bring out the big guns. That's when you reach for something like piperacillin-tazobactam or carbapenem. You just need that much broader coverage.
And please, remember this critical practice update. For years, penicillin was the go-to. Not anymore. Using penicillin by itself is like bringing a knife to a gunfight these days. There's just too much resistance among the key oral anaerobic bacteria. You have to use something that covers those beta-lactamase producers, or you're risking treatment failure. And that brings us all the way back to the beginning. How do we stop these life-threatening emergencies from ever happening? We prevent them. It's really that simple. Public health wins like water fluoridation, combined with good old-fashioned brushing, cutting down on sugar, and seeing a dentist regularly, that's the ultimate intervention.
So the next time a patient comes to you complaining of a toothache, I hope you'll see the bigger picture. Remember those anatomical highways, look for the red flags like trismus or numbness, and know when to get that CT scan. By understanding this whole process, you can be the one to intervene before a simple cavity becomes a systemic crisis. You might just save a life. Thanks for tuning in.